I wanted to say, when Rod came to, whatever his name is, when he came to Michigan, he's made it clear he came as a cardiologist, but when he left, he became a nuclear oncologist, and I feel like in my career, if I had any impact on that, that was perhaps the most important contribution I've made to the field. So I know it was only a small part, but just wanted to congratulate you, and what you've done in the last 2 decades is frankly remarkable. The other thing I wanted to point out was I did teach Dr. Hicks how to give lectures. Lots of slides, and don't worry about how long it's supposed to be. So in the spirit of that education, when I was preparing this, I had a preliminary program that said my talk was to be an hour. When I checked last night, it said on the final program that it was supposed to be 25 minutes or something like that, 30 minutes. So I left it at an hour. But I did try to cut it down a lot, and I knew that I wouldn't really be able to bring a whole lot new in terms of scientific information here. But I thought I maybe would bring some perspectives that might be new. And for those of you who don't know, I moved to St. Louis about 2 years ago. I had been in Baltimore for a while, and then before that was in Michigan. But I had originally done my medical training and my radiology and nuclear medicine training at Washington University in St. Louis. So I had a chance to go back there, and it seemed like a good opportunity. So I moved back. But with the move, anytime you move, I'm doing more probably administrative things now. So my perspective is a little more at the perhaps at the healthcare delivery system level, and I wanted to maybe emphasize a few of those issues here. A few disclosures that I don't think really make too much difference to this talk. And I'm going to just skip through some of this stuff, highlight some stuff on diagnostics, highlight a little bit about quantification, talk a little bit about radiopharmaceutical therapy, and then talk about how this fits in economically depending on your healthcare system. And I thought SPECT is getting kind of short shrift today, so I thought I should say a few words about SPECT, even though the topic was PET and Theranostics, because single photon imaging, it's been around a long time. We haven't been able to kill it off yet with PET, but it does have the advantage that you only have a photon being emitted. You don't have these highly energetic beta plus particles, which deliver substantial radiation and which make using long-lived half-lives difficult. So if you want to do really good dosimetry, I think single photon emitters still have advantages because they don't because of the imaging characteristics being able to give a larger dose for a longer period of time. It's arguable. I think copper is a big deal. We actually make copper 64 and sell it all over the country in the US with our cyclotrons. But I think the SPECT is still interesting. I think it's worth pointing out there's been a lot of work in quantitative SPECT. I wanted to just highlight this. The major manufacturers all have quantitative SPECT machines. I'm not trying to say this is any particular vendor, but you can see that this is a gamma camera, but this is a fully digital detector. One could argue, is this a huge advance? It's an iterative, incremental advance, but I think the fact that we're still seeing progress in our instrumentation is important because, as was pointed out, that the instrumentation and a lot of other aspects are important to make all of this stuff actually work. So progress in instrumentation is going to help us diagnose and treat cancer. And we actually had a field upgrade done on this. This is a fully CZT, but the advantage of these devices may not look overwhelming, but they have better energy resolution. And this better energy resolution may allow us better quantitation by getting more of the relevant photons. They also have higher resolution with this sort of device, and even though you see the sensitivity, there's a little bit of a trade-off here. But there is progress with gamma cameras, and I think the quantitative gamma camera imaging is important because there are studies showing that it's relatively repeatable. And I like this term. I like to call it the SPECT UV instead of the SUV in a Higgsian manner to come up with some kind of pun. But the SPECT UV is pretty repeatable for indium-111 octreotide SPECT, and I think our ability to measure with relative certainty the uptake of radioactivity in tissues is going to be very important as we move the field ahead, because I fully agree that personalizing dosimetry to personalize therapy will be important. One dose fits all is not really so rational. Now, we're going to hear a whole lot more about PSMA imaging and so on, but I think maybe one of the killer apps for PET MR, I think two of the important ones are with prostate cancer imaging. The other one is a neurofibroma and the transformation to malignant peripheral nerve sheath tumors. So these kind of devices I also think are important, and I think you're going to have one or two of them here. I think it's worth noting that this instrumentation I think is particularly relevant for children. There's more and more data showing that repeated anesthetic exposure in children decreases their cognitive function with age, and it's highly relevant to cancer patients who are imaged repeatedly. So if you have to put a child under general anesthesia many times, the more they're under general anesthesia, the less good it is for the brain. Now, there may be other factors, but this seems to be emerging. There's animal data to support that. The PET-MR actually lets you do the PET and the MR data at the same time, quite obviously, hence the integrated system. But this, I think one of the advantages will be less anesthesia, and I think less, that will be advantageous. And also, if you look at total cost, having a kid asleep for multiple hours costs a lot of money in terms of the team engagement. So some of these devices, I think, are going to have key niches, and I think in the cancer patient they'll be important. So what about PET imaging of cancer? We've heard a lot. I think it may be useful to look at the US framework. It's about as crazy as any other country, but sometimes the US healthcare system influences how care is delivered elsewhere. So for a while, we had the US Pharmacopoeia monograph. We still have those. But if agents were in the USP, they could be used in clinical practice. So when I moved to Hopkins in 2000, we were able to do C11 methionine. We could do C11 acetate. We could do N13 ammonia. A lot of different things that sort of oldies but goodies that we knew worked under the USP rules. But the FDA rules changed several years ago in the US, and now the FDA must approve essentially all PET agents for human use. So the fluorodopa, among others, are no longer so easy to use in terms of clinical care in the US. We need a so-called NDA or a amended new drug amendment to do this. And this is, sometimes this requires payment. So the regulatory steps are more complicated. And this has made doing PET more difficult in the US, particularly for innovative agents and to move things from the lab to practice. Now, needless to say, the FDA has a lot of rules. Indeed, there's an A to Z list of regulated products and procedures, which I would not encourage you to read, but you should know that this is required. But there are several agents that are now approved, and FDG, C11 choline, gallium-68 dotatate, F18 flucivacone, sodium fluoride, among others. So I'll show you a couple things. This got approved quite recently. This is a synthetic amino acid. Here's an example of this. This was developed at Emory. Very nice images. And this was, I thought, good news. This is May of 2016. This is an FDA news release. This is a new agent to detect recurrent prostate cancer. Now, this was approved, now, mind you, May of 2016. And the head of the FDA cancer imaging branch said, you can, that is helpful. And the brand name of this is Axumin, provides another accurate imaging approach for these patients. Recurrent prostate cancer when the PSA is at low level. So this is good. I wanted to just show you that was, this doesn't, in the US, unlike Japan, when you get FDA approval, it does not mean that there will be payment by CMS, which is Medicare. It often means it, but it doesn't mean it will occur immediately. So this is some very recent news that as of January 2017, Medicare will pay for this F18 radiopeptide. So that's good. That's a national decision that covers 80 million potential patients. And this is some of the words here. Interestingly enough, and this is almost unheard of, they wanted to pay $400 per 0.1 millicuries. Based on this math, a dose, the FDA stated that, or the CMS stated they would pay $40,000 per diagnostic dose. This turned out to be an error. So we don't actually know what they're going to charge or pay, but they will pay. And this is one of the few times I've ever seen radiopharmaceuticals actually being reimbursed higher than we expected. But this error was quickly identified. But if you look here, this is a lot of stuff, but it turns out that Medicare, though it's one entity, has a whole bunch of different contractors that handle how the details are processed by state. So 5 of 8, it turns out there's 8 Medicare administrative contractors in the US, and 5 of the 8 have figured out how to do it, and the other 3, which are a significant number of states, are still working on it. So just wanted to illustrate that the idea of getting FDA approval and payment used to be pretty closely linked, but now in the US, there is this issue where they're not so closely linked. And I'll come back to that. Here's another one. This is NetSpot. This was approved June 1st, 2016. So a major advance in the US, the gallium-68 approved by Medicare. And I point out that this same Lou Marzella, very nice man actually, talks about how great this is for neuroendocrine tumors. And interestingly enough, this was also approved for use in children. So this is a good approval as well. So this is encouraging in the US as regards availability of these agents. So we were kind of late to the party, but eventually the lessons of the global experience helped these agents get approved, mainly based on global experiences with the agents. So how else can we in the US get PET agents or diagnostic agents into patients? We can use what's known as investigational new drug application with cost recovery. So you can actually make an agent in your lab, and if you follow the rules, you can bring some of these agents to patients with recovery of costs of making the radiopharmaceutical. So the University of Iowa has done this with radiopeptide imaging. UCSF is doing this with radiopeptide imaging for prostate cancer. The problem sometimes is that the patients obviously don't have the money to pay for these scans. Medicare hasn't approved it, and many insurers will not pay. Despite that, some individuals get access by self-pay. Here's an IND. Here's a compassionate IND. This is another way. This is an I-124 patient we did when we were at Hopkins, when I was at Hopkins, and this patient has metastatic disease in the lungs and brain metastases, and this was really instrumental for calculating the patient dose, because this patient had a low dose of I-131 on board, which was complicating our dosimetry calculations. And because of the lung activity, we had to do some specific dosimetry for the lungs in this patient who was, I think at the time, 11 years old. So our challenges include these USP agents are no longer available without an IND. This payment lags. There are now processes like the CMS registry for sodium fluoride. We can get it on Medicare patients, but have to send in forms. But then the other problem is we have 80 million people covered by Medicare, but then about 10% of the US population is not covered with insurance, but the rest are covered with Obamacare, which I don't know if you've ever heard of Obamacare, but it's an aggregation of a variety of insurance policies, which are essentially private insurance for patients who are not old enough to have Medicare. So I guess what I'm trying to point out is, like, the US has crazy healthcare, but it is highly heterogeneous, and I want you to learn something from this experience. So many private insurers, despite these drugs being FDA approved, are not paying for them because they want to save money, or else they just don't know. So we can have imaging agents for PET, diagnostic agents which are FDA approved, paid for by US Medicare, but not available to patients covered by private insurance because they have low-cost premiums. So the way this happens, this is probably more information than you want to hear, but it's just kind of interesting to see how this is working, having been involved in PET from very early on, to see what the barriers are as you try to take this to a population, and to a population so you can manage individuals, is that there are radiology benefit managers. Here's something that just came out, let's see, in the last couple of weeks. This is 190 pages about what scans can be done and what scans can't be done. Interestingly enough, there's no mention of the agents which are approved for neuroendocrine tumors for the gallium or for the new prostate imaging agents. They're just considered experimental. And there tends to be a bias that the private carriers use these radiology benefit managers to deny access to patients of these newer agents. So there's a lot of paradoxes. It's one of my, I guess I was paradoxically saying this a lot, but it's expensive. Well, anyway, the thought is that expensive and minimally effective therapeutics are paid for sort of without question by insurance, but imaging agents which could guide these therapeutics are often not paid for. So this is kind of really a strange situation. Hopefully one will be able to get through with logic. But as I think you may find out that, as Dr. Hicks pointed out, I think we have the same politicians in the U.S. As in Australia, or I guess they're somehow, there are some behaviors that are across countries. So Obamacare. So in the U.S., Obamacare has made insurance available to many more individuals than before. So the number of uninsured has dropped substantially, which is a big achievement. But to do that, a lot of the sick people have insurance, so the well people have to pay more. That's the way insurance typically works. But now, in addition to paying health insurance, a deductible of, let's say, $6,500 is typical for a so-called silver plan. So this is a working person would pay health insurance and then would in addition have to spend $6,500 before insurance would start to kick in. Then insurance would pay 80% of the cost. There's a lot of commentary, but this is just when I was looking at the internet, source of all information. This is a patient who was trying to figure out what to do because he was covered by insurance. He says, I voted for this, I'm for the health plan, but I can't afford anything anymore. I'm only going to be able to see a doctor in the ER. Who can I turn to? The answer on this was, well, we're sorry about that. But it is an interesting situation that these high deductibles may make it less likely that patients will go for sort of preventive care because this is coming out of pocket. But luckily, we have a solution in the U.S. Some of you may be aware that an election is coming up, and so I've been pretty much assured that PET tracer reimbursement will be great again. Of course, this isn't necessarily, this is probably not the result we'll have, and it's also possible that that the current policies may change only gradually, and the PET reimbursement may not be changing so rapidly. Of course, I just wanted you to know that this isn't, issues like this aren't unique to the U.S. I happened to pull this one off about European approval, and somehow the European medical agency, prematurely notified the public that the kit was approved and then had to take it back. I think they're going to approve it, but this whole, there's strange things in this whole reimbursement space. So luckily, I moved to St. Louis, and whoever's elected, my job next week is to make the Mallinckrodt Institute of Radiology great again. This is what my residents made this. I don't know that that's a job description. Anyway, so what about the U.S.? A lot about reimbursement, but it really does affect our lives. This is a tracer that was developed at Hopkins. This is Marty Pomper, and we did this in the PET Center. This is very nice agent. I think this has a lot of promise. This is a PSMA agent with F18 labeling. There's a variety of these. F18 has some advantages over gallium, I think, with a longer half-life and the ability to distribute it. This is some work published by Steve Rowe, one of our former trainees. This is, I think, a very impressive agent. But we really are kind of facing this kind of existential question of how do we value imaging? How do we assess the value of imaging? I think I did a bad thing here. Oh, there we go. So I just, as an international perspective, I thought I'd take you through some of the issues we're working through in the U.S. about value. Now, we've had sort of fee-for-service medicine for a long time. You do some work as a radiologist or nuclear medicine physician, you get paid under the resource-based relative value scale. And there's a group of doctors who get together and figure out how much your work is worth and how much time it takes to do something, and it's under the relative Value Uptake, Relative Value Scale Uptake Committee, the RUC. I've actually gone to this committee and presented how much time it takes to get ready to do a PET scan, to read a PET scan, and so on. And these kind of discussions, which are like a feeding frenzy, help determine how much reimbursement will be given to physicians for interpreting these studies. So there's a work RVU and a practice expense RVU. This is pretty well established. This has been going probably for 20 years. There's a variety of steps. It's the RUC goes, Medicare looks at, CMS. There's further reconciliation. They look some more, Medicare decides, and then there's a final valuation. So this is how in the US the work of interpreting studies is valued, not the cost of the radiopharmaceutical. But in 2015, you may have seen this, that we're going to change all of this. Now, we don't have a lot of evidence to support how we're going to do it, but it sounds like a good plan, and it does really sound attractive. The head of Medicare said we're going to set value-based payment goals to improve US healthcare. Payments linked to quality or value by Medicare. And I think that this particular approach is going to have some global impact in that this idea, if it is, linking what you're paid to how valuable it is, probably makes some sense. And so there'll be this transition from volume driving success to value driving success, in principle. The problem we have is that we don't quite know what value is in our field, and this is somewhat arguable. Anyway, these arrows are kind of neat. I don't actually know what they mean, but I thought it was, I think it means that if you don't do volume before we switch to value, you run out of money and you go out of business. So I think there are risks with this, okay? So this is the sort of imaging 2.0 to imaging 3.0, and we saw this, the Eric Topol slide. Eric and I were junior faculty together at Michigan as well, interestingly enough, that Dr. Hoffman showed. But there's these, trying to move from volume to value, from transactional to consultative, to patient-centered, outcomes-focused, integrated, and accountable. And I think that these are all good lessons. I think regardless of your healthcare system, you kind of want to have this. But the key for imaging is demonstrating value. And the trouble of determining value is it's a moving and evolving target. And one other thing that I think has come out a lot is radiation dose is a major concern, and our driving it downward is actually very important, I think, societally. In the last couple of months, I've seen data showing that the EPA in the US, the people who regulate how many miles per gallon your car has to get, and how much carbon can come out, and how much Volkswagen can put into the exhaust, these people are now going to regulate radiation dose to society. So at least this is on the books. So radiation dose is a real consideration. So we have to think about that as we do our studies. And we also know that too much inappropriate imaging with radiation will just decrease value. Anyway, so I think we're going to be increasingly required to value our technologies even more clearly before they're introduced, or they may not be compensated adequately as healthcare delivery funding sort of moves to these alternate payment systems, which are not volume driven. So I think if you step back globally, what's important in life? Countries with high GDP can spend more, but I think most societies would say it would be of high value to have good health over a long lifespan. I think most people would probably say that. How imaging contributes to this is variably proposed, and this is undergoing rapid change. And we have to be, as a field, think about what is valuable and how do we, as professionals, align what we do and collect the data to show the value of what we do in our studies, in addition to the traditional diagnostic metrics of sensitivity and specificity. So I think I'll just skip through this. I mean, imaging can be over and underutilized, and even in countries with high GDP, there can be heterogeneity of use. But this is getting all kinds of attention, mainly probably because most people in radiology in nuclear medicine are worried that this whole approach may devalue what we do and maybe threaten the existence of our field. So those are things that would get your attention. The American College of Radiology has said that value is equal to quality divided by cost. You can see and do an equation that makes sense. But it isn't absolutely clear if high quality is always going to result in better outcomes. So I was thinking about how to get here today. Could I walk? Could I take the tram? Could I take a taxi? In other words, if you're trying to get to a destination, you need to get to the destination. Do you need to get there in a Mercedes, or is riding the bus okay? So quality isn't necessarily, in my estimation, the right metric. It's a component. But I do think outcomes are what we have to think of, relevant outcomes to patients and society. Quality is important, but it doesn't count, I think, if it doesn't improve outcomes. So if we find 122 lesions with one agent and we find 64 lesions with the other, does the finding of the extra, 2x or whatever, really improve outcomes? So I think we have to be very careful not to delude ourselves that some of the things we do may not improve outcomes. I personally, though, think in general, higher diagnostic accuracy tests are obviously going to improve outcomes. But strangely enough, society seems to want more than knowing the test works to show that outcomes are better. Very hard to get quality adjusted life years when imaging is only one part of the whole chain. So it's strange, but value is in the eye of the beholder, and the different members of different beholders may have different perceptions of value of what we do. So I think that this will impact our theranostic and diagnostic use. So patients, society, insurers, employers, the government, the ordering physicians, the performing physicians, hospital leaders, and so on, social media, your Facebook family, they may have differing views of the value of exactly the same thing. And one of the challenges is who's making the decisions for the availability of your agent. So I do think we're going to increasingly be required to have outcome metrics relevant to patients as part of our studies. And if we say that the quality of life of a patient receiving peptide radiotherapy is better than chemotherapy, we should be collecting the data on resource consumption and patient well-being, quality of life, and some of these other metrics in all of our studies. So we're prepared to show that, if the outcomes are not necessarily longer survival, if it's quality of life or resources, that we've got those data. Because I think these are hard decisions that societies have to make. Again, this is more or less the same thing, but really kind of interesting to look at the different perspectives. Patients want everything great for free, and I'm a patient at times, and I would like that, but health systems don't want to do all of that because they would go out of business, and society wants something in between. So really, these are difficult choices. Luckily, in addition to the FDA covering the ABCs, Medicare now has a bunch of new things called alternate payment models in the US, and it's just unbelievable how much change there is. Luckily, we only get to V so far, but I'm sure we'll soon to be to Z. But if you see, the first one is alternative payment model. That's not fee for service. The last one is value-based payment modifier and value-based purchasing. So these value metrics are going to change and affect how we do our studies and how we do our procedures. Now, I don't know if I believe this, but it's been estimated that waste is a third of the US healthcare. I think that's possibly correct. The only problem is we're not quite sure what third it is. And I mentioned this as well. This radiation dose is getting more and more attention. And in the US, and I suspect this will be globally, the radiation dose must be specified, and varying states are putting out data on this. So this will no doubt apply to Theranostics as well. And if you've got 3 different Theranostics, it may be the one with the best radiation dose profile is the one that wins, even if the patient has fairly advanced cancer and they're going to get treated in other ways. Okay, so wonderful work has been done here. I would just point out a little bit of the US experience in reimbursement with the National Oncologic PET Registry. Barry Siegel, the late Ed Coleman, Bruce Hillner, Tony Shields worked on this. Hundreds of millions of dollars were spent by CMS to look at to make FDG PET available and look at how doctors wanted to use the studies. Here's some early data, but basically this is from 34,000 patients. Most of the time, what happened, and this is similar to the data here, there was a change in management, sometimes major, sometimes minor, but the majority of times there were changes, and it was almost at each stage at diagnosis, mid-treatment, and at time of suspected recurrence. we're probably going to need to be very careful to continue to collect data like this longer than we would expect in countries where these agents are not yet made available through the healthcare system. So, I mean, these registry data are very important, and I know that under this value-based system that the U.S. is coming up with, registries of radiation dose are becoming one of the tools which are applied, and I think outcomes-related registries will be seen as well. So, you know, I think that the bar continues to be raised to introduce new approaches into practice. Some years ago, we were quite interested in trying to systematize response measurements. I would only point out that I think for our imaging tests, quantitation will come forward, and obviously FDG is really important. I do think a great opportunity, not yet fully answered, is trying to figure out how to deal with immune-based therapies, where our FDG breaks down, and we can see instances like this where the signal actually goes up with effective therapy due to infiltration of activated lymphocytes and reactivation of them in tumors. So here's a case. We see a melanoma metastasis in the left high axilla. 4 weeks after anti-CTLA-4 treatment, we see increased FDG uptake and the lesion has enlarged, and then keep treating 4 months later. This is now essentially resolved. So we have some interesting diagnostic challenges, but the reason I show this particular one is it turns out that one immune treatment agent is not enough. In fact, it turns out that if you combined a CTLA-4 inhibitor and a PD-1 inhibitor, nivolumab and ipilimumab, which costs about $200,000 a year, it works better. But not about half the patients respond. So if we could figure out with these scans really who's going to respond and who isn't, it would hugely impact society in the US with this very expensive therapy. So the therapies are becoming so expensive that better agents and systematic reporting will be important. So why don't we perform enough randomized trials of imaging? Well, I guess I'm pretty guilty of that. I mean, sometimes with FDG and some of the stuff is so obvious it works, it seems like it would be unethical to do some of these studies. As Rod pointed out, that the studies in head and neck cancer, they had survival data long before the randomized trial in the New England Journal of Medicine, and long before that, we had, of course, shown that FDG was superior, you know, years ago to MR and CT foretelling about recurrence after treatment. So there's been and even had it paid for by Medicare based on those data. So, but in the UK, they were able to do some of this stuff because they couldn't make FDG PET available everywhere. So there are some opportunities. We'll come back to that. But I do think it is important to think about doing these studies, but there can be major issues because they may not be viewed as ethical depending on where they're being performed. And not much government funding, but here are studies that I think we could use more of to have level 1 data where patients are randomized to the new imaging test or the new theranostic test, diagnostic test, imaging performed or not performed, complete conventional therapy in one group, use image-informed therapy in the other, look at outcomes, cost, quality of life. I think we have to be mindful that these studies have to be done for us to continue to grow our field, and we need to do these sooner rather than later. We don't necessarily benefit by having 30 different somatostatin receptor imaging agents and have no randomized trial that shows outcomes are better as a result of them. I mean, I worry that our field to some extent has ADHD for radio tracers. It's always fun to do another one, but at the end of the day, it's nice to get one figured out really high level. So response adaptive therapy, this has been done in lymphoma. I'll kind of skip through this. There are more and more trials where PET can be used to intensify therapy. We did an early one when I was at Hopkins, and I'll just refer you to it, but the patients who were in a high-risk group received stem cell transplant, and they were actually randomized. They had much better outcomes than expected. Non-randomized is now being done randomized. And I'll quickly take you through this because Dr. Hicks referred to this. This was in New England Journal a few months ago. This was presented as a plenary session paper at ASCO. And this is I'll show you the design here. This is to determine the efficacy and cost efficacy of PET-CT guided scanning compared to a planned neck dissection in patients with head and neck cancer. But you may have seen this, but this is a multi-center study. I wanted to point out the number of authors, this was a whole bunch of different sites in the UK of varying, some academic, some not so academic, but almost 600 patients. And they basically they would be planned to receive a neck dissection, and assuming their disease hadn't progressed, they'd have surgery. And over here, same kind of thing. They'd have their chemoradiotherapy. If the PET scan was negative, they would be watched. If the PET scan was positive, they would go to surgery. But you had the possibility, if the head and neck PET was negative, that they would not have surgery. So a little aggressive, could you have microscopic disease missed by PET? Maybe so. So eliminating surgery in the PET negative group. What they found was that the neck dissection group, these are really essentially equivalent, was slightly less good, at least on this curve, than the PET surveillance group. So really, the control arm, anyway, it actually did really well. And this actually showed a hazard ratio in favor of doing the PET as opposed to doing the surgery. Now, one could argue this study shouldn't have been done because it was obvious it would be, that PET CT would be useful, but I don't think you really knew till you do it. And the one thing, the PET CT is certainly not inferior to surgery first. And the other thing interesting about this trial was, in addition to excellent outcomes, it costs less per quality adjusted life year and per patient to do the PET CT. So the cost savings by including PET CT in this were $2,165. Well, at least it used to be. It's less savings now since the pound has gone down, but still a significant cost savings. So this is the sort of ideal situation where you do a diagnostic test, an advanced diagnostic test that costs a fair amount of money, but you actually save money. So they concluded survival was similar, but they had fewer surgeries and it was more cost effective. So this was actually an example of doing better with less. We had better care for individuals and the population, lower costs through improved technology. There was more imaging and less surgery. So essentially we eliminated ineffective, I use the term we as a field, ineffective cancer therapy. And I think this kind of study is extremely important. And I know you want to give me the hook, but do I have a few more minutes? Is that all right? All right, good. Now, the other thing you could do is do better with more. So let's say you have better care and better health for the population, but it costs more. You might do this through more imaging or more surgery. And I won't, this is not a, this has been approved in the US, and I just pointed out lung cancer screening. So lung cancer screening with CT in high-risk populations falls into that. And there is evidence now that this now covered fully by Obamacare is cost savings. But the thing is, the cost per quality adjusted life year varies depending on the status of the patient. So it just goes to show you that as we talk about imaging and what's useful and what isn't, there are major differences depending on the specific risk groups of patients and how old they are, whether they're past smokers or current smokers. So to say one test is really always cost effective is an overgeneralization. And I think as we mature in our understanding of imaging as a field, we will see that there are some situations where what we're doing makes a big difference, and others it may just not be affordable. Everybody would say, hey, $43,000 per quality adjusted life year, that's really very attractive. $600,000 is a lot harder to justify. And it turns out that there's a lot of differences, and more people argue about this. It turns out that pessimists and optimists have differences in terms of what they think the value of a quality adjusted life year is. So it goes to, again, show you how society makes decisions is influenced by the composition of society and obviously by the GDP. Now, Dr. Baum couldn't be here, but I want to talk a little bit about therapy. Well, since I'm already over my time, a little more about therapy. This book is really long that came out. I would suggest you look at it, but I thought it was interesting because it goes out to page 941 to show you how much interest there is in therapeutic nuclear medicine. And this has really, really grown as a field. And I'd like to just highlight a few things. I also wanted to comment that Richard and I were hosts of helped organize that Theranostic meeting in Baltimore last time, and we were really delighted that this wonderful venue is in place for this Theranostic meeting here. And I got to say, it's a lot prettier here than it was in downtown Baltimore. So in any case, a few highlights. Dosimetry, I think, very important. This is patient-specific, I think, will become the norm. This can help us. This is I-131. This is some data that Steve Larson and colleagues published. Ways to take our standard, or let's say after the Saul Hertz initial introduction, but years later, ways to improve the uptake of existing tracers. We should not lose sight of the fact that this biology can not only increase radiosensitivity, but depending on how we handle things, might actually improve radiotracer delivery. Precision Medicine Initiative, this is another initiative in the US. This is underfunded at the moment, a lot of interest. That and the Cancer Moonshot, unfortunately, both still relatively undersupported, but bringing a lot of interest to cancer. And of course, I-131 was truly the first precision therapeutic, but you just gave it and it worked. I'd like to just say a couple words about anti-CD20. I think one trip when I was here a number of years ago, I talked about I-131 anti-CD20 therapy. This involved the use of a tracer dose and a therapeutic dose, a dosimetric dose of I-131 tazotuzumab, whole body counting, simple dosimetry, and a patient-specific therapeutic dose. And this particular therapy ended up being FDA approved as Bexar. But one of the lessons learned along the way, and I think relevant to other therapies, is that the mass that you give makes a difference. And this was a low protein mass, all going to the spleen almost, and here's a much higher protein predose. The ability to image where our agent goes is really important, and we should not lose track of the importance of mass as we work with our radiopharmaceuticals. Not all masses behave in the same way. Also, lessons learned, I mean, we were able to retreat some patients. This was a mouse antibody, but the ability to retreat and re-establish responses is important. The concept that we can just give one dose and expect it to work, I think, was pretty naive. We did that at that time because we had murine antibodies and had a risk of not being able to do repeated therapy. There were a lot of mistakes along the way, and I'll talk about that later this week, but that we never tried to get FDA approval for this as a single initial therapy. And the initial therapy in 76 patients showed a 95% response rate, and this is some old data, but this is out to 10 years now with excellent survival. So we have that, and we have Zevalin. These are therapeutics that are available in the U.S. Or have been. Unfortunately, with the Bexar agent, the comparison in a large study to chemotherapy followed by radioimmunotherapy and chemotherapy followed by rituximab, these really were overlapping. And then what happened was there was progress in our other therapies. I think we have to be mindful of this. I think most oncologists would rather give the patient a pill than give them radioactivity. So we have to keep an eye on what other therapies are going to be available. This is not just a pill, but this kind of therapy with bendamustine rituximab really was better than R-CHOP. And based on this, this agent, which was approved for about a decade, left the market. It just was not having sufficient sales to continue. So it's exciting to get a drug approved, but it's also important that its efficacy be in the context of the healthcare system you're located in. Luckily, in Australia, you can still get I-131 rituximab. In the U.S., we also have the therapeutic approved Yttrium-90 Zevalin. This is not heavily used, and I think that I've heard rumors that the use is declining. It is well tolerated in the elderly. It also can be given at high doses for myeloablative radioimmunotherapy. The group at City of Hope have pioneered in this. We've done a little bit when I was at Hopkins with patient-specific dosimetry in which we use this indium as a surrogate for the yttrium biodistribution, but with combined SPECT and planar imaging, we're able to get dosimetry and found that there was about a twofold difference, able to give doses up to 5 times the normal FDA-approved dose, 6 times, and had about a 86% response rate. Small study, but again, using dosimetry to guide therapy to doses higher than our standard dose. So the dose escalation is possible, and I think that theme will prevail, though it is additional labor. Rod mentioned I-131-MIBG. I would only say that the safest trials, particularly in children where this is increasingly the norm, have been informed by at least simple dosimetry in my estimation. The safety appears better with such approaches. Another therapy, Yttrium-90 Microspheres, there's a couple of agents approved in the US. The ability to do post-treatment dose validation is quite important, and it represents an opportunity theranostically as well with both PET and actually brimstolin scanning. And of course, globally, radium-223 is, I think, a therapeutic, theranostic. I mean, you have the diagnostic with F18 and the radium as the therapeutic, and this is being used. There is competition for other therapies with this agent. And we know that in randomized data, well known, that the radium prolongs lifespan versus placebo in prostate cancer. But there are a number of other agents, and I think how this exactly fits in still is under study. This is well tolerated, 6 doses. In the US, it's about a $70,000 therapy. So what about therapeutics in the US? We heard a lot about this. The data I had, and again, I mean, I know the most recent data is that in the US, the I-177 labeled somatostatin analog, Lutathera, is under assessment by the FDA, and hopefully we'll know by December 28, 2016, whether it will be approved. There may be additional data, but we are hopeful that this kind of agent will be approved in the US. And interestingly, therapeutics in the US have been much less of a problem to get paid for than diagnostics. Alphas versus betas, we heard a lot about this. I think alphas are good. I just wanted to highlight that in the US, there are alpha particle emitters in clinical trials. This is 213 bismuth, anti-CD33 for leukemia. This showed anti-leukemic effect in the Sloan Kettering group. We had a chance to participate in a study with actinium-225 anti-CD33, this particular trial, when I was in Baltimore, and a little complicated. Elderly with leukemia, a lot of steps to do this. It's an outpatient therapy, but this is an ongoing trial. We had some patients who had declines, pretty significant declines in marrow blasts, but very, very early work. There's concerns about global supply of actinium. This is moving slowly, and I think we only contributed 1 out of this bunch of patients. The other study that's up, we have this in process, is anti-CD45. This has a commercial sponsor as well for acute myelogenous leukemia as a myeloconditioning regimen. This is some work that's come out of University of Washington with iodinated antibody. The patient gets very high doses, up to 1,000 millicuries, is hospitalized for up to 6 or 7 days, then receives a transplant. So it's somewhat laborious, and we'll see how it works commercially. It's kind of a tour de force to pull it off, but it is feasible. And this particular trial is now ongoing. There's there's crossover and so on. It's anyway, hopefully it'll fly. It's in process. I think this paper, this is out of date. In 2010, we looked at the view on radioimmunotherapy, and at that time, it was still most of the oncologists were optimistic about the growth of this area in lymphoma. One of the interesting things I think worth pointing out is that we did a survey, and I thought this particular one was quite interesting. It would be economically adverse for my practice to use this therapy. This is highly significant between academic and non-academic physicians. So it turned out that this was buried in a survey, but the private practitioners found the economic model in the US was unattractive for them to refer patients for radioimmunotherapy. Obviously, a healthcare system should not have those kind of incentives built into it so that the physician would consider this a negative for patient care. There's plenty of other negatives, including this one here, too many other effective non-radioactive treatments for patients with lymphoma. So, but just something to keep in mind that the system may make a difference. So I talked a little bit about healthcare delivery, and I think that, of course, you know, if you're in a free market system, the stock market is supposed to tell you everything. I'm not going to say what company this is, but this is a company that purports to make, this is a US company, purports to make radio-labeled antibodies for clinical trials. We see their stock has dropped from $12.50 to $1 at the time I made this graph. This is regarding radioimmunotherapy. Now here's a company that makes radiopeptides and say they're going to do radiopeptide therapy, and their stock, it looks like it went from something like $25 to almost $40. So the markets are saying peptide therapy is very attractive, and the radioantibody therapy, though there are trials, don't seem to be as attractive to investors. So I think you're convincing, or we are convincing people about peptides. Finally, and I know that's the word you wanted to hear, proper training. We really have to think about how do we train people. Maybe it's happening globally, but in the US perspective, I think we're not adequately training the next generation of people to do radiopharmaceutical therapy. Who are they going to be? Kind of a hybrid between radiology, nuclear medicine, radiation oncology, and you know, this is a disruptive technology. It's somewhat different than what we've done historically. And I think we have to be realistic. We still have major limitations for Theranostics of limited delivery to the tumor and too much to normal tissues, limiting efficacy. Some of this may be existential in a way. If there's not enough blood flow, you got to get blood flow to a tumor pretty much, or else it doesn't flow there, you're not going to kill it. So these areas with low flow and hypoxia, I think, represent major challenges. Some of our agents just don't have high enough therapeutic margins. Of course, we can still do stem cell support, and that's a real plus. And second organ toxicity can probably be avoided by really good dosimetry. The other thing I think Dr. Hicks has shown, single agents is expecting a lot for us to treat all cancer. Combinations with other treatments are essential, I think. Collaboration and integration with other oncologics and the right people. These incentives are so important for our diagnostics and therapeutics so that our system doesn't distort their utilization. And I think the peptides really have made great advantages. So I think we have to be careful. The innovator's dilemma. We definitely we need to change the status quo, but we don't want to fall into this area here where we've got the science done, but yet the system doesn't allow the new innovation to become part of our practice. So I think the future of PET agents is bright, despite these challenges in reimbursement. The future of Theranostics is also improving, can be complicated by unusual payment systems. That's true for diagnostics as well. And I think the workforce represents a challenge for us so that we have the right people to move this forward. Thank you, and I'd like to thank my colleagues. Obviously, some of the stuff I showed was done at Hopkins and at Michigan before I moved to St. Louis, and these people contributed greatly to this. And thanks for the invitation.